Good morning, good afternoon, good evening, wherever you are when you're watching this. This is Howard Goldman from Cleveland, Ohio, Cleveland Clinic, and I'm very happy that you've joined us for this industry theater about macroplastique, tried and true. Dr. Abbas Shoberi, who's from Innova Women's Hospital, will be working on this together with me. And what we'd like to do is really just take you through some of our thoughts and some of the data on why really macroplastique is our injectable of choice at this point. As you can see, I'm from Cleveland, Ohio, and I'm glad you're with us. Laborie was kind enough to invite me to participate in this, and we're going to start by talking a little bit about the role of bulking agents in the treatment of stress incontinence, go on to discuss patient selection, outcomes, some tips and tricks, and then some of the advantages of macroplastique. So macroplastique is a synthetic material. It's a silicone elastomer that's non-allergenic, soft. It's not resorbed, it doesn't degrade, and it does not migrate. And it is suspended in a inert liquid that is excreted unmetabolized. This elastomer, once it's put in, it is encapsulated in fibrin, keeps its original volume, and ultimately collagen is deposited throughout the matrix. This helps prevent migration and movement and maintains its suppleness. I bring up this publication, which as you can see is from 1996. So this had, at that point already, 3 years of follow-up. Bottom line is, the reason I bring this up is to show you that this material has been around for a long time. And I think that's an important quality in many of the things we utilize now. We've all seen some products which come out with a fanfare, sound great, but then a few years later you may be sorry that you tried them. This is something that's been around for a long time, and I think if there were any serious adverse issues, we would have known about it a long time ago. And we know that it works. You can see even in this study years ago, half were dry improved at 3 years. Let's look at the AUA SUFU guidelines, which I was lucky enough to be part of. And in those guidelines, it says that bulking agents are one of the standard treatments that should be considered besides the various other more invasive surgical treatments. And what it says is bulking agents are viable treatments for stress incontinence, and the role of bulking agents may be best considered in patients who want to avoid more invasive surgical management, or perhaps patients who've had a previous failed procedure or a procedure where they benefited, but not quite as much as they'd like. Now, traditionally, the good bulking agent candidates were thought to be those without hypermobility and with significant IST, but there's plenty of literature that even those with hypermobility do well. I would suggest that from a clinical standpoint, patients with failed incontinence surgery, those who maybe are not candidates for going to the operating room, patients who don't want surgery right now, or perhaps, particularly in today's world where there are many patients who may be concerned with the use of mesh slings, bulking agents, and particularly macroplastique, is a very reasonable option. So let's look at some of the data. This is an interesting study from just published last year. All the patients had at least 3 years of follow-up. And the interesting thing here is that all of these patients just received one injection. Now these patients, some had hypermobility, some did not, so it took all of them. And as opposed to the way many of us practice, where if we did an injection and it wore off or it failed, we might try another one. In this paper, it was a one-time shot and that was it. And even with that, you can see that at 3 years, both objectively and subjectively, there's a roughly 50% cure rate. And when you look at improvement, you can see if you look at very much better or much better on the PGI, almost 2/3 of the patients at 3 years had sustained improvement with one injection. As far as adverse events, really minimal. And as they say here, these 3-year results show that this is an acceptable treatment for stress incontinence with stable results over time and a negligible complication rate. Here's another study, also recent, that looked at macroplastique for patients with ISD. And what they did is they actually divided into 3 groups. Those who had never had anything before, those that had had prior incontinence surgery, and those who had had prior incontinence surgery and a bulking agent injection. And success was answering question 3 on the UDI-6 with either a 0, which means dry, or a 1, and having had no reoperation for stress incontinence. And you can see the results, depending on the group, went from about 40 to 65%. And interestingly, the ones who did the best were those who'd had prior surgery with the bulking agent. This is a systematic review and meta-analysis of macroplastique where they looked at over 900 patients. Now, if we look at the conclusions of this meta-analysis, they found that macroplastique sustains its benefit in the mid and long term, and also did note that this may be best suited to women who desire long-term significant improvement or cure.
I'm Laborie, and I will be talking about the 1 to 3 year follow-up of macroplastic injection studies. In the first study that I will be presenting to you, this is a multi-center randomized controlled single-blind study that enrolled 247 female patients with ISD who were randomized 1-to-1 and treated with transurethral injection of macroplastic or Contagen. Repeat treatment was allowed after the 3-month follow-up. Effectiveness was determined 12 months after the last treatment using STAMI grade, pad weight, and urinary incontinence quality of life scale scores. For those of you who don't remember what the STAMI score is, 0 means that the patient is totally continent. 1 is when the patient has some leakage of urine with extreme activities, and a score of 2 are the patients that we generally see in our clinic with urinary incontinence, and a score of 3 will be total incontinence. So in this study, at 12 months, 62% of patients with macroplastic versus 47% of patients with Contagen had an improvement with the STAMI score of 0 or 1. And this was statistically significant with P of less than 0.05. 37% of patients were dry, which means that the STAMI score was 0. Then 1 hour pad weight decrease was 25.4 milliliter from the baseline. And the mean improvement in urinary incontinence quality of life scale score was 28.7. In another study utilizing the same cohort, 67 patients who were diagnosed with stress urinary incontinence primarily due to ISD and were successfully treated with macroplastic were evaluated for the durability of the macroplastic for SUI in a 24-month follow-up study when these patients have had successful outcome at 12 months after their last injection. So we have a cohort of patients that had successful treatment at 12 months, and now we are evaluating at 24 months. So in these 67 patients, 84% had sustained success since 12 months. 67% of them were dry with the STAMI grade of 0. And of the dry patients at 12 months, 87% maintained cure at 24 months. 41% of the patients who consider themselves improved, which means that they had a STAMI score of 1 at 12 months, were dry at 24 months with a STAMI score of 0. So the overall incontinence quality of life scores and all subscales showed statistically significant improvement from baseline with P of less than 0.001. Mean pad weight was 24 grams at baseline and 4 grams at 12 and 24 months. Patient and physician assessments rated 85% of patients dry or markedly improved 24 months after the last treatment. In the last study that I will be presenting, this study was presented as an abstract at OGS and SUFU. The authors investigated 3-year follow-up treatment of patients with macroplastic. So this was a retrospective review of 276 subjects who enrolled in a multicenter study between October of 2008 and August of 2017. Of these, 70 subjects were available for 3-year follow-up, and they were treated with up to 2 macroplastic injections as necessary and followed at 3, 12, 24, and 36 months. The measures used were STEMI grade, the quality of life questionnaire, and the patient global impression of satisfaction score. So as you can see here, the mean age of the patients was 63.3. 34% of participants underwent 2 injections, and 30% had STEMI grade of 0, 40% had a STEMI grade of 1, and the overall satisfaction was 68%. 38.5% were very satisfied on the PGIS score. As you can see on the graph here, once they reached to the 12 months, their satisfaction was maintained into the 3rd year of treatment. So in conclusion, we have reviewed the 1 and 2 and 3-year follow-up studies, which has shown macroplastic is safe and efficacious for the treatment of SUI secondary to ISD in women. An overall high satisfaction rate is sustained from baseline up to 3 years post-injection. At this point, I would like to turn the podium over to Dr. Goldman, who will be talking about tips and tricks. Thank you.
Now, some of the tips and tricks for injection. So we often do a urethral block first, and that's very simple. We just inject a little lidocaine perimeatally at the 4 and 8 o'clock position. We try to set up all of the injection material prior to the injection. Use a short-beaked injection scope, which we'll come to in a minute. And also, since there is a little bit of learning curve as to how to do this, though I like to do these in the office, but I would recommend doing the first few in the surgery center or something like that. And then once you get it down, transferring it to the office setting. So this is the actual injection device. Here's the needle, here's the material, and then you just set it up with this injection device, which as you squeeze it, it provides the pressure that pushes the macroplastic out. Now let's look at a short video that goes over some of these points, and you'll see this is just a model, so I'm not wearing gloves, but let's take it away. You'll need a scope. One very important thing to tell people who are learning how to do this is it's critical to have a scope with a small beak. So this is a special injection scope that can be used for bulking agents, can be used for Botox, things like that. But the beak is very short. So essentially where the lens is and where the water comes out are very close to each other. If you use a regular scope with a regular beak, the beak goes back to about here. And so what happens is the water's coming in here. And so if you move to the mid-urethra or beyond the mid-urethra where you would be injecting the macroplastic, the water flows actually outside the meatus, and thus you don't get distension of the urethra. So always use a short beak or a special scope. Now we're going to go ahead and take the macroplastic out. So we'll open it there. It's always doubly wrapped. So that's ready. Now we'll open the needle. And again, there's a special needle which is utilized for this. You can't utilize other types of injection needles that are utilized for, let's say, Botox, because with this material and device, this is very, very viscous, so it takes a lot of pressure to get it to flow. and so they have a metallic needle. And so putting this all together, essentially we go ahead and put the syringe through that. We then let the back part, press on this button, let that fall back, and we line up the dots with the opening there, put it in, and then give it a twist. So now it's in securely, and then we attach the needle. And it's important to attach the needle very tightly because it's so viscous that if you don't attach it tightly, as you start to pump it, there's a lot of pressure that's needed because of the viscosity, and it'll actually start to work itself around the threads and come out here if it's not done tightly. Then we prime it. So give it a few pushes till the material's at the end. There it is. Now we have to push this button back here to sort of hold off on the pressure. Now we're ready to inject. Now some people in real life do that priming part once it's in the bladder and you can see the tip in the bladder. So now we take our scope, we make sure there's the nipple on the end that we're going to pass the needle through. We close that outflow tract. You then go ahead and put the needle through the opening here and pass it till you can just about see it coming out the tip. And then for the real world and what we'll do in the models, you kind of back it up so it's back in the scope. And then we're going to hook a light cord up, and then we're going to place it in the urethra. So we're now going to place the scope into the bladder. Again, then we'll insert the needle. And then you'll see there are some marks on the needle. There's the first one, that's about 1/2 centimeter, and there's a second one that's another 1/2 centimeter. So what we're going to do is we're going to sort of see how the needle lays within the urethra to determine where we actually do the injection. So theoretically, if you want the bulking to be in this area of the urethra, I'm going to put the needle there and then back the scope up. So there's the first mark and there's the second mark. So what I know is that I want to kind of inject into the urethral lining somewhere around this area, and that'll put me at the proper area from the in the urethra, just beyond the bladder neck is where we want the bulking to occur. Okay, so now we're actually going to inject. We're going to start with the bottom one over here. So we'll go in at about a 30 to 45 degree angle. And then once we get to the first black mark, which is there, we'll bring it out more to a 0. Then we get to the 0, or the second black mark, we can start injecting. So now we're going to inject. So you see that little bulge occurring. And that's what it's supposed to look like, where it starts to fill that area. Okay. And after 30 seconds, you also push the button here to take the pressure off. Wait 30 seconds, and then you withdraw. Okay, so we've got the nice one there at the base, and now we're going to go to the side. And it's a little harder to see the side, but there we kind of went in at the angle. There's the first one, now we make it even, and now we go to the second one. And let's see what happens now. So you see how that's kind of bulking? So this is actually what our lateral bulking just looked like.
So why macroplastique? Again, as I noted earlier, this has been around for a long time. It's got a good track record with a nice cure and improvement at mid-long-term outcomes. Migration has not been seen, it doesn't degrade, and you get a stable response. This can be done either in the OR or, as I preferred, in the office.
Okay, why don't we go over some cases, and between Dr. Shaberi and myself, we can sort of see how some real-life patients played out. So this is my first case. This is a 57-year-old woman who presented with recurrent stress incontinence after a transobturator sling. She didn't complain of any urgency. She said that her urinary flow was normal. On exam with a cough, she leaked very clearly. Q-tip test was 0 to 20 degrees. Post-void residual was 45 cc's. So one thing that I did do before I was going to go ahead is my practice is anyone that I'm going to do a procedure on, potentially, who's had a prior sling, I usually cysto them myself, just because I'd hate to get involved in something and then find out that there was a sling somewhere that it shouldn't be. So we did do a cystoscopy, which was normal. And in a case like this, personally, I would not do a urodynamics because I think it's pretty straightforward, but certainly some might. Abbas, what are some of the treatment options you would discuss with this patient?
So with this patient, in terms of their treatment, we would do urodynamics on the patient in my practice, but mainly because if it's primary incontinence, we would go by the ACOG criteria that just the demonstration of SUI is enough. But if they have had a prior sling, we would subject them to urodynamics. But after that, if they have had a failed transobturator tape, I really don't think pelvic floor therapy would be much of benefit for them unless on the examination you decide that they really don't have good control of their pelvic floor and they just need a pelvic floor tune-up. But besides that, I think we would either offer them a retropubic synthetic sling, or if the patient doesn't want to have additional surgeries, macroplastic is a great option for her.
Okay, so we did discuss all of those things, really the full, what I call my full spectrum for someone who has failed a prior sling. Typically, though, I would focus in on a bulking agent like Macroplastique or doing a retropubic midurethral sling. There are some patients who, for whatever reason, have been scared by commercials they see about mesh, or they already had a mesh sling and they failed, and they decide they don't want a mesh sling. But I would certainly, in a case like this, if that was the case, move much quicker to Macroplastique, which is much more minimally invasive than going on to an autologous fascial sling. And in fact, this patient did not want any more surgery, and so Macroplastique was a really nice option for her. We did one tube. I know it talks about the standard protocol is to often use 2 tubes, so half a tube on one side, half a tube on the other side, and then some on the bottom. In her case, we just did half a tube on either side. We had very good bulking, and she was very happy. And on 6-month follow-up, she had minimal leakage, but ultimately was very happy with it. And so we sat tight at that point. Any thoughts, Abbas?
I think that's very much a reasonable option and a great outcome for the patient. So I will be presenting the next case, and this is a 60-year-old woman, no prior surgeries, comes with stress urinary incontinence for the past year. She doesn't have any prolapse on physical examination, and she does have a positive stress test. Post-void residual is 30. All of our patients that come in, we generally have them do a Euroflow if they have urinary issues, and she had a normal flow pattern. On examination, the Q-tip testing is she doesn't have hypermobility, and we did do a urodynamics testing with low leak point pressure because mainly because when she exerted herself as we were examining her with the slightest exertion, she was leaking. We were really interested in knowing how low her pressures were. So Goldman, how would you manage this patient?
So, the guidelines say try pelvic floor therapy, and we can certainly try that. I have a feeling it's not going to work with such a low leak point pressure. I doubt it'll work. I would really talk to her about Macroplastique versus a retropubic sling, retropubic synthetic sling. I think the retropubic or all the midurethral slings work better in patients who do have some mobility. So I would quote her a lower success rate than what I usually quote. But I think it certainly is an option. On the other hand, Macroplastique or a bulking agent would be perfect. This is sort of the ideal patient for a bulking agent.
I agree. So this patient underwent macroplastic injection, as we discussed, and she did quite well at the follow-up examination, was able to empty her bladder, and she was dry. And we also did an ultrasound on her, as you can see here. This comes from one of our publications, and you can see, just to orient the audience here, so this is, I'm going to draw here, this is her pubic symphysis. The transducer is inside the vagina here. So we are looking anteriorly, and we can see the urethra is drawn here in this line. The patient's bladder is up here. And then we can see her macroplastic is nicely applied all around the urethra. Actually, when we look at it, you can see that it's to the left and right and also circumferential. So this is a nice application of macroplastic for a primary patient with incontinence. And this is her ultrasound.
So tell me more about the ultrasound, because I don't use ultrasound at all for any of these patients. Is this something you're just doing for academic interest and teaching, or is this something that's you think is necessary?
So whether you have, whether you do ultrasound or not, it has to do with the availability and your skill level. For this case, we are presenting it for educational and research purposes and for the audience to know where the macroplastic goes and what it does. And for us, it has been impressive in terms of the fact that when we image patients with macroplastic versus the other type of bulking agents, macroplastic seem to have a more reliable application in terms of where it's supposed to go. And we'll show that in some other cases as well.
So I would take from what you just said that ultrasound probably not necessary to do when you're doing these, but from an academic standpoint, it actually is very nice because it seems to confirm that this bulking agent is more likely to be where you would expect it to be than perhaps others.
Absolutely. So in these lectures and with the video demonstrations and the cases that we have presented, we have presented the long-term track record over the past 20 years that macroplastic has. And we have also talked about multiple studies that show the safety and efficacy of macroplastic injections. Macroplastic has more studies and more rigorous sample sizes than the other agents that are on the market, the bulking agents that are on the market. We viewed it as a minimally invasive procedure that can also be performed in the office, has very low adverse event rate. As I said, in my mind, when I say adverse event is either a patient being incontinent or not being able to void, nothing more serious than that. And then it just demonstrates significant improvement rate for the patients. And again, in my hands and Howard's hand, if you have appropriate selection, the patient should have very good outcome.
With that, on behalf of Dr. Laborie and myself, I really want to thank the ICS for giving us this opportunity to have this discussion. I want to thank Laborie for sponsoring this. And I'd like to wish all the attendees of the ICS, I hope you had or are having a good meeting. All the best. Thank you.
Thank you.